Hi, my name is Dr. Charlotte Acor. I'm a board certified ophthalmologist and I'm one of the few fellowship trained pediatric ophthalmologists in West Texas, and I'm also a billing and coding expert. Today, welcome to my Facebook Live television show, and today I'd like to discuss modifiers. I'm actually going to do a series of modifiers, and the focus of today's modifier is actually modifier 25. Now you ask, why is billing and coding so important? Because you need to do it properly. It's a way to make sure that you're compensated appropriately for your work, and also when you use certain codes, you're actually being graded against your peers. So even if you are on salary and you think it doesn't matter what you bill and code, your employer wants to make sure that you're paying your way or bringing in your worth. So it's important to know billing and coding, and you may not always be an employee, or even as an employee, they're not going to keep you around if you are not keeping your word. So today I'd like to focus on modifier 25, and it's always best to get the definition of the codes from the CPT book. Today I'm going to just discuss modifier 25 in relationship to CMS, the Center of Medicaid Services, how they really want modifier 25 to be clarified. So modifier 25 is a number that you put next to your evaluation and management code to indicate that you have done a separate and identifiable different service from the point of the visit. So, for example, I'm an ophthalmologist. Well, if somebody complains of blurry vision, I would do the eye exam. I would take their history. I would check their vision. Most likely, if it was their first appointment, I would dilate them and check their retina. But then they would say, "Hey doc, I have this bump on my eye." So then I would do a procedure called a chalazion incision, where we numb the medicine and we cut the bump. So if the patient was complaining of blurry vision, but also detected on exam was the bump, the chalazion, in order to be paid for both, I would use my E&M code, put a modifier 25, and then also put the procedure code for the chalazion. An example for this in relationship to cardiology is if someone comes and they're complaining of chest pain and the doctor is evaluating them and also checking their cholesterol and the hypertension, and then the cardiologist performs a stress test. Obviously the cardiologist performed a complete examination, and he also is performing a stress test. So he would use his E&M codes for evaluation of the hypertension, the high cholesterol, and he would use his chest pain code for the stress test. So one thing that CMS actually recommends or is looking for, and even private insurance companies are looking for, that separate and identifiable service, but also that separate and identifiable service has to have a different diagnosis code from the procedure. So for example, in the case of my example I gave for eyes and the chalazion, my blurry vision can be due to nearsightedness, but the chalazion is the diagnosis code that I actually attach to the procedure. And the same thing, so I know if a patient, so for example, if a patient came in follow-up and just complained of the bump and said, "Hey doc, I have a bump," and I cut away a bump, I would be incorrect to use the modifier code 25, because really the patient came for the chalazion excision, and yes, I had to evaluate it, but it's not a huge separate and identifiable service. And then another example in relationship to the cardiology example, if you brought a patient back to have a history and physical to make sure that they were healthy enough to have that stress test that you wanted to perform at a later visit, so you're bringing them for the history and physical to do the stress test that day, the history and physical isn't really a separate and identifiable service. That history and physical is being done because you want to have the patient do the stress test. So you're really bringing the patient back for that stress test, and there's not really a different diagnosis that you're checking up on. So one thing that in the primary care world that has a lot of controversy, and more probably in the controversy of the patient where they receive a bill, is where Medicare allows one routine or one history and physical checkup every year. So then when a patient says, well, I just want my yearly checkup exam, and then the patient starts complaining of problems, so then the doctor bills for their yearly maintenance visit, but then they also put that modifier 25 on there, and then they bill for a code to identify the actual medical manage of complex diseases. And so yes, you are justified to bill your history and physical visit, whatever code Medicare tells you can use, and you can bill your E&M code and put that 25 because you're identifying two separate problems, your history and physical, just making sure the person's healthy, and then second, the diabetes management or the hypertensive management or the asthma management. However, patients are often confused. So it's important that the doctor knows what they're billing, so they can explain it to the patient, and they can educate their staff to explain it to the patient. So you knowing how your codes are being used and how you're using it so that you can explain it to your staffs, because ultimately if the patient, even though you're justified in billing it, if the patient feels like they were cheated or they got a bill unfairly, then that's going to ruin your patient relationship and then ultimately affect your business and your compensation. So my name is Dr. Charlotte Acor. I'm a board certified ophthalmologist and billing and coding expert. I'd like you to join me every Tuesday at 6:20 Eastern Standard Time, 5:20 Central Standard Time for the billing and coding update. Here on Facebook, you can find me Facebook at DRCHARLOTTEMD, and I'm on Twitter, Instagram, and that's my social media handles. And to make sure that we actually get through some more material and information, I'm going to actually start coming on Thursdays and Saturday morning. So people find billing and coding sometimes overwhelming because it's something that they don't teach us in residency. So people are like, oh, I'm not really good at it, but it's just something that takes practice, just like it took you 3 years to become a pediatrician or internist. It took me 6 years to become a fellowship trained pediatric ophthalmologist. So it's just something that you need to practice every day. But if you learn it, you can make sure your compensation is adequate, and also that you can also explain those things to your patient, because at this day and age, medicine cannot be void of the compensation angle or aspect. I know that sometimes as direct primary care doctors and concierge doctors, they can set their fee schedule, but when you work for yourself and are taking insurance, you have to know the rules, and that will help you know what to expect in the billing and coding world and keep up to date with changes. So again, my name is Dr. Charlotte Acor. I'm a pediatric ophthalmologist and coding specialist, and please tune in